Hi, my name is Erin Shalene, and today's date is 3/3/2024. Today I'm going to discuss with you Case 1 and Case 4. Case 1 is about a newborn girl who's experiencing elevated levels of ammonia. In order to get a better understanding of this, I would like to discuss with you the key components that make up an ammonia transfer by this visual diagram here. So as you can see, you start off with a transamination reaction. Transamination reactions start off with an enzyme, either an alanine aminotransferase or aspartate aminotransferase, and the cofactor paradoxal phosphate. You have the amino group alanine and then alpha ketoglutarate. What happens is alanine, the NH3 is removed from there and applied to the alpha ketoglutarate. The products formed are pyruvate and glutamate. In the case for an AST transamination reactions, you start off with oxaloacetate and glutamate. The products formed from that are aspartate and alpha ketoglutarate. From there, you're into the liver. At the liver, you start off with glutamate. Glutamate will go through a deamination, and that uses the enzyme glutamate dehydrogenase and requires NADH and NADPH. The results of this form an alpha ketoglutarate and the ammonia, which is then sent to the urea cycle. Also, you have in the peripheral tissues glutamate. Unfortunately, glutamate is not able to travel from the peripheral tissues through the blood to the liver. What ends up having to happen is that it needs a different way to transport the ammonia. This is done by transferring it over to glutamine. This is done through the enzyme glutamine synthetase that ends up converting glutamate to glutamine. This is able to happen because glutamine becomes neutral by the addition of two amino groups. Once glutamine travels from the blood, then it arrives to the liver. Once at the liver, then the glutamine will then get converted back to glutamate. This is done by the enzyme glutaminase. From there, the glutamate that's formed then goes through deamination again, as we previously discussed, and has the production of ammonia to release to the urea cycle. These are the components that make up the ammonia and how we are able to transfer ammonia and get it all the way to the liver to be able to be filtered out from the kidneys into the urea cycle. Now, one might ask, how is nitrogen transport connected to gluconeogenesis in the fasted state? Well, as previously discussed, the pyruvate that is formed from the first transamination reaction I discussed, the alanine aminotransferase, is taken back through the above steps of the alanine glucose cycle, also known as the Cahill cycle. That pyruvate is then produced back into the Krebs cycle, and from there it is converted back to oxaloacetate. Oxaloacetate is unable to leave the mitochondria. At that point, it needs a shuttle. The shuttle ends up using malate to be able to transfer out of the mitochondrial membrane. From there, the malate is then converted back to oxaloacetate, and the pathway continues through gluconeogenesis in order to produce the product of glucose. After further analysis of the labs, it shows that the urine orotic acid levels were marked elevated at 473, and the plasma citrulline levels were considered normal at 10. So in this individual where orotic acid levels are elevated and uric cycle enzyme that is most likely deficient is ornithine transcarbamylase is the enzyme that is considered deficient. How I was able to come to that conclusion is because there was an elevated level of orotic acid levels. That tells me An enzyme below that it has the deficit, which would then cause an uptake or elevation of the orotic acid levels. That's how I was able to determine a deficiency in ornithine, also known as the enzyme OTC. From there, I noticed that the citrulline levels were normal, so it had to determine what was the least likely to be impaired enzyme, and that would be carbamyl phosphate synthetase 1. How I got to that answer was I considered two potential enzymes, carbamyl phosphate synthetase 1 or OTC. Knowing that OTC was affected due to the elevated levels of orotic acid, that could be ruled out, which then gave me carbamyl phosphate synthetase, which you need carbamyl phosphate synthetase plus the ornithine combined to form citrulline. That's how I was able to determine that it was carbamyl phosphate synthetase 1 that it would be most likely not deficient in this situation. Now, the question comes, which amino acid, if any, become essential as a result of this deficiency? Yes, when there's a deficiency in the uric acid cycle, there ends up becoming an essential amino acid, and in this case, it's arginine. And this only occurs when there's a deficiency in the uric acid cycle. So this gives you a better understanding of case number 1, and I'd like to switch over to case number 2. Case number 2 is a 58-year-old woman that's showing signs of fatigue, shortness of breath, heart murmur, rapid heart rate, and neurological signs and symptoms. I'd like to rule out potentially 3 different vitamin deficiencies. The first being iron and B6. The reason I was able to rule out iron, though it had similar symptoms to megaloblastic anemia, the patient did not have blood in their stool and no significant blood loss. That's how I was able to rule out iron deficiency not being one of the vitamins this patient was deficient in. From there, I looked at vitamin B6 and looked at the signs and symptoms typically presented, which was altered mental state, dermatitis, neuropathy, and anemia, in addition to having a past medical history of seizures, and it also can be caused by a malabsorptive condition. This patient did not show signs of a seizure disorder in childhood, so in addition to having a malabsorptive condition, so I was able to rule out vitamin B6 deficiency, which leads me to believe this patient is suffering from a vitamin B12 deficiency. The clinical presentations of this deficiency are shortness of breath, tachycardia, weakness, heart murmur, paresthesia, balance difficulties, and neuropathy. The patient did mention the past 6 months they've been feeling fatigued and short of breath, in addition to having numbness and tingling. On exam, I noticed there was a rapid heart rate, paresthesia, and a heart murmur. This would lead me to believe this patient does have a deficiency in vitamin B12. From there, this vitamin deficiency does play an impact on pyrimidine metabolism. Before I go into pyrimidine metabolism, I would like to give you a better understanding on how vitamin B12 plays a role between the pathway between methionine and cysteine. After a series of steps in the methionine-cysteine pathway, it reaches the portion called homocysteine. From there, it can either go right to cysteine or go through the process of remethylation to form methionine. When going through this process of remethylation, this involves vitamins B9, which is folate, as well as vitamin B12, cobalamin, which are both needed in order to complete the step. The issue is, if there's a deficiency in B12, then remethylation cannot occur and methionine cannot be formed then. If methionine cannot be formed, this will cause a buildup of homocysteine. Due to not being able to form methionine, this leads to pyrimidine metabolism being affected. When the above processes were occurring, the byproducts of remethylation are not able to be formed, which is methyl THF, and the simpler form of it is THF. By not having these byproducts, these become the intermediates for pyrimidine metabolism. Since we no longer have these byproducts, we are not able to create pyrimidine bases, and that is how this can affect pyrimidine metabolism by having a B12 deficiency. And the final potential laboratory test that I would like to use to rule out differential diagnoses for a vitamin B12 deficiency are the following. I would like to complete the following lab tests: either methylmalonic acid, check homocysteine levels, as well as evaluate red cell folate assay. By looking at these different tests, I'm able to determine if it's more of a B9 deficiency or a B12 deficiency. If it's a B12 deficiency, I can determine that diagnosis by methylmalonic acid levels as well as homocysteine levels. If it's a B9 deficiency, the test results would be in favor of the red cell folate assay. That's how I'm able to differentiate between B9 and B12. Thank you so much for your time, and I appreciate it.